सागर सागर अरे ये इकडे ये. सुधीर 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 अरे इकडे चालेल आहे. चालू चालू करावं लागेल.
तुम्ही काय नाही अडचण द्यायला पाहिजे तर लोक येतात.
ठीक आहे असं त्याला बोलू ना. रुबीवाल्याला बोलू रुबीवाल्याला बोलू.
4-5-10 लोक
तू इंदापूरवरती ह्याच्यावर टाक आता. नाही आत्ताची लिंक नवीन करावी लागली मला. त्याला बोलव ना. त्या सागरला बोलव की. अरे सागर कुठे आहे? सागर त्याला पाठवा. सागर सागर हां लाईव्ह. हा पकडायचं. सुरुवातीचं सगळं रेकॉर्ड करा. नंतर मग मॉब वाढल्यानंतर इकडे हे करा.
स्टार्ट केले का रेकॉर्ड?
हा चालू आहे आता. चालू करू पटकन.
सर 2 मिनिट. कर की. नाही करत, नाही करत. सर इकडे बघा सर. चालू आहे ना?
हां चालू आहे ना, चालू आहे चालू आहे.
स्टँड नाही केला. स्टँड कुठं आहे? त्याला स्टँड हां सर. हां हां सागरला पाठवून द्या. सागर हां ते बघ. फॅन बंद झाली तर फॅन का बंद केला ए सी चालू केला ऐसे
On behalf of Indian Media Association, I welcome Good evening, everybody. On behalf of Indian Medical Association, I welcome all the esteemed speakers of today's session, all delegates of IMA, NIMA, and Homeopathic Associations of Indapur. After a long break of 2 months, when we have conducted state level conference in the country of 2023. Already we are today. We will proceed for today's first lecture. Today's first lecture is rational use of antibiotics by Dr. Prasad Solution, sir. Sir has done numerous MD, critical care medicine, and he is consultant intensive state research at Rupee House since 10 years. Please welcome Dr. Prasad Solution. Thank you.
So good evening all. Thanks, I am Indapur for the inviting me. So today we will discuss regarding the novel topic regarding the rational use of antibiotics. So severe infection, we already know it is the most common indication that patient can admit in the hospital, even in the ICU. Irrespective of the specialty, all physician is using the antibiotics. And the most global threat nowadays is the resistance of currently present antibiotic, and the antibiotics which are in the pipelines are very less. So this is a global threat. The already antibiotics are very less, and the present antibiotics is there, and there is increased resistance for that antibiotic. So therefore, the most important thing is the judicious use of appropriate use of that antibiotics. Okay, so if we know the pharmacokinetic, pharmacodynamic of that antibiotics, those indications, so we can reserve the antibiotic for the next generation, even for the future. So for that, individualizing dosing regarding the pharmacokinetic and pharmacodynamics characteristics are important to optimize the use of that antibiotics. And we know that in the critically ill patient, the pharmacokinetic is changing. So accordingly, we can change the dose duration of the antibiotic and just individualizing dosing is the most important thing regarding the antibiotic use. So we'll discuss regarding the most common indications, most common organism and which antibiotic is preferred for that disease. So most common ICU admissions or in hospital is your community acquired pneumonia. So organism which can cause community acquired pneumonia are Streptococcus pneumoniae more than 50%. Nowadays there is increased trends regarding the gram-negative infections. So that is Klebsiella, influenza, Racemotobacter, Pseudomonas, atypical organisms like Mycoplasma, and we already know COVID or H1N1. So viruses like influenza and also global threat. So these are increased and it can cause the community acquired pneumonia. Those who are having structural lung disease, there is increased trends regarding the increased incidence of Pseudomonas infection. So, regarding the multi-drug resistance infection, if patient is already receiving the antibiotics, yes, age more than 65, those who are already on the dialysis, home care, if patient is on immunosuppression medicine, so in that case there is increased resistance, multi-drug resistance organism infection. So, for the community acquired pneumonia, those patient who is having the infection with the lungs, okay, so appropriate use of the antibiotics within first hour, golden 1 hour from the ICU admission is necessary. And before starting the antibiotics for this patient, you can send the appropriate cultures, maybe your sputum, then endotracheal aspirate, blood culture, whether the antigen, or if required, bronchoalveolar, lavage samples, we can send for this patient. So, for the patient having community acquired pneumonia requiring ICU admission, we initially receive the combination of the antibiotics. So, community acquired pneumonia, the guidelines says that we can start with the combination of the antibiotic with the two different class of antibiotics. So, most common antibiotics which is used for community acquired pneumonia is your cefotaxime, ceftriaxone, or amoxicillin clavulanic acid, along with your macrolide antibiotics like azithromycin or clarithromycin. So these are used where you are not suspecting the Pseudomonas infection. So, and in the penicillin allergy patient, we cannot start with the third generation cephalosporin. So in that case, we can start with your fluoroquinolones. So levofloxacin is also good for the chest infection, moxifloxacin or ciprofloxacin. Along with the astronom, we can use for the community acquired. So in the case where we cannot use the macrolide like azithromycin, so in that case we can use the fluoroquinolones antibiotics for this patient. If we are considering the Pseudomonas infection, so in that case anti-Pseudomonas antibiotics like your cefotaxime, ceftazidime, ceftriaxone, your beta-lactam inhibitors like your piperacillin tazobactam, or combination of your 4th generation cephalosporin, or maybe carbapenems like imipenem, meropenem, and 4th generation cephalosporin like CP5 can be used whenever we are suspecting the Pseudomonas infection in the community acquired pneumonia. So for community acquired pneumonia, just start with the combination of the antibiotic therapy. So we can use the aminoglycosides or macrolide antibiotics along with the your cephalosporin and carbapenem. Now, rate of MRSA in our community is very less. So, if you are suspecting this patient is having methicillin resistance type 4 years, then we can add the vancomycin or teicoplanin, which has a good chest penetration. Linezolid is also option where whenever we get the vancomycin resistance or when the patient is having any kidney injuries, so in that case we can start with the linezolid for that patient. So empirical antibiotics with anaerobe. So when to use your metronidazole. So whenever you are suspecting the lung abscess, empyema or necrotizing pneumonia. So in that case, we can add the your metronidazole in your combination of the therapy. So regarding the duration of the therapy for community acquired pneumonia, so duration is we can use the antibiotic for 7 to 10 days. So it is appropriate. So they have done the studies whether 7 to 10 days or 10 to 15 days. So both are having equal efficacy. So we can start the antibiotic for 7 to 10 days in this case. Whenever you are suspecting the Pseudomonas, you can extend the duration for 14 days. And for the necrotizing pneumonia, so we can extend the duration up to 3 weeks. for the community acquired immunity. Now, regarding the duration of the therapy, we can individualize, like according to the organism, response to that patient, and severity of the disease. If patient is having good clinical response, patient is hemodynamically stable, we can shorten the duration of therapy for 7 to 10 days. Now, for the de-escalation of the antibiotics, procalcitonin can be helpful. So, we can take a help of procalcitonin or biochemical test, which can be done to just de-escalate the antibiotics. So, whenever we start the antibiotic for any patient, and after that duration, if your procalcitonin is decreasing trends or become normal, so we can cut down the therapy for 7 to 10 days. Now, most important, whenever any patient is admitted in the ICU for some another threats, maybe your head injury or any other surgeries, and if patient is on the ventilator, and after 48 hours, if that patient develops the fever, bilateral consolidation, we can suspect the ventilatory associated pneumonia in that case. So, for the ventilatory associated pneumonia or healthcare or hospital acquired pneumonia, so most common organism is your gram-negative. More than 95% of the patient is having gram-negative infection. Klebsiella, Acinetobacter, and Pseudomonas. So these are the most common threats. Less than 10% of the patient may having the gram-positive, that is your Staph aureus. So for Indian ICU, so there is one study, INDICAP is done in the 2016. So they have done this study in Indian ICU. What is going in Indian ICU? What is their common prescription pattern? So they have done this study in 150 ICUs and more than 1,000 patients are included. So this is a point surveillance study and the results are very interesting. So they found that if 60% of the patients receive the antibiotic, but that physician doesn't know the indication, that means this patient doesn't have any infection, still that patient received the antibiotic. So this is very life-threatening. That means if you are starting the antibiotic for that patient, so it increases the resistance for that antibiotic also, and there is an enzyme induction in that organism, and that can cause the multi-drug resistance organism. So if you are using that antibiotic frequently in your ICU, so in some next 5 to 10 years we get the resistance. So for the ventilatory associated pneumonia, more than 80% of the patient is having MDR infection, multi-drug resistance. So they are not have sensitivity for your cephalosporin, beta-lactam is inhibitor like piperacillin. So in that case, we have only choice, that is carbapenem or newer antibiotics like colistin. So for ventilatory associated pneumonia, more than 85% to 90% is your gram-negative infection. So combination of therapy is not required in this case. So both are equally efficacious, combination of the therapy or monotherapy. So we can start the single antibiotic for that patient. The most common antibiotic used for the ventilatory associated pneumonia is your piperacillin tazobactam, like beta-lactam is inhibitor, your imipenem, meropenem, that is carbapenem, or levofloxacin, and 4th generation cephalosporin, that's CP5 and CP5. Now, if you are suspecting the gram-positive infection, so in our area, we doesn't get the more frequent gram-positive chest infection. So MRSA is very less, but if you are suspecting the MRSA, then your glycopeptide like vancomycin, linezolid, we can use for this patient. But the problem with the linezolid is that it can cause thrombocytopenia and gastrointestinal severe adverse effect. And remember, we are residing in the country where there is a tuberculosis is an endemic. So we can use judiciously these antibiotics which can be used for the XDR or MDR tuberculosis. So linezolid, aminoglycosides and fluoroquinolones, we have to restrict the use for your common practice like for the pneumonia and abdominal infection. So whenever we are suspecting the ventilatory associated pneumonia and the drug resistance or the MDR infection is very less, we can use single antibiotic which can cover your Pseudomonas or methicillin sensitive Staph aureus. So in the area where your MDR infection rate is more than 15%, or whenever we get commonly multi-drug resistance infection, so you use 2 drugs from the different class. Now regarding the colistin, it is not recommended for the routine use. Okay, because if you use routinely colistin, then first thing you get the resistance for the colistin. We cannot give the monotherapy of the colistin. Then combination of the therapy is required with the colistin, and most important thing is the drug dose adjustment. So colistin is a nephrotoxic, so patient develops the acute kidney injury if you are using the colistin. Second thing, the penetration of the colistin is very poor, like the brain infection, CNS infection. So empirically we cannot use the colistin for this infection. So already we covered, we cannot use judiciously aminoglycosides, chloropheniramines and linezolid, because we are residing in the country where tuberculosis is very high and we have to preserve these drugs for the tuberculosis. Now, suppose we get the infection, everybody should know the which infection is common in their area. Like that, we have to discuss with the microbiologist which infection is common in our area, which infection, because in our OB hall also, suppose we get one infection like Klebsiella in ICU, but for the surgical ICU that Klebsiella is different, so they have different susceptibility patterns. So we cannot use same antibiotic in the same unit or in the different unit. So that's why we have to discuss with the antibiotics with the microbiologist, which organism is common, what is the sensitivity pattern for that antibiotics, and then we can start empirical antibiotic according to the microbiological data. Now for ventilatory associated pneumonia, shorter duration, that is 7 to 10 days is enough. Longer duration is used in the patient where patient is having immunocompromised state, like uncontrolled diabetes, patient is on immunocompromised medications, or whenever we get a pseudomonas infection or structural lung disease. So in that case, we can use the increase the duration up to 14 days. Even in the VAP also, we can use the procalcitonin just to de-escalate the antibiotic. Now, whenever we start an antibiotic for anything, like for the chest infection, abdominal infection, we should give some time for that antibiotics. That antibiotic should get some time, that is 40 to 72 hours to work. Because if you start the antibiotic for any disease and tomorrow doesn't get any response, you will change the antibiotic. It's not like that. So at least 48 to 72 hours is required for any antibiotic to working to start work. And then we have to decide whether to change the antibiotic according to the cultural data. If you are getting the sensitivity report, we can de-escalate the antibiotic. We can see the clinical response. If patient is already on the medications to increase the blood pressure, that your noradrenaline, adrenaline, on ventilatory support, patient is hemodynamically unstable. So if patient is hemodynamically stable, there is a good clinical response, blood pressure is normal, ventilator requirement is reduced. So in that case, we can just continue the antibiotic for that disease. So just give 48 to 72 hours for any antibiotic to work. After that, just de-escalate or escalate the therapy. Now, whenever we get the treatment failure for the VAP, so any patient who is having immunosuppression medication, advanced age, chronic lung disease, multi-drug resistance infection, so, or inadequate dose, inadequate duration of the antibiotic, or whenever there is a poor source control, that means if patient is having lung abscess or emphysema. So source important is the most important thing, because if you are giving antibiotic therapy and source control is poor, antibiotic is not going to work in this case. Now next most common infection is your catheter related blood stack infection. So most common factor is your duration of the catheter. So increase the duration of the catheter, we can get the more infection with the catheter side. If patient is on immunosuppression medication, uncontrolled diabetes, sepsis, or high Apache score, that means patient is unstable at the time of admission. So in that case, we get a high chance of catheter-related blood step infection. Now, which are the most common organisms that can cause catheter-related? These are the gram-positive organisms. That is Coagulus negative Staphylococcus, your Staph aureus, Enterococcus, and Candida. So these are the most common alternative. Now, whenever we get a gram-negative infection, so empirical antibiotics should include your gram-negative infection antibiotics like your 4th generation cephalosporin, your beta-lactamase inhibitors like your piperacillin tazobactam, and your carbapenem. So we can use these antibiotics. So those patient who is having abdominal surgery, unstable patient, poor response to the antibiotics, so in that case we can start the empirical antifungal therapy. Fluconazole is having good antifungal cover, so if patient is hemodynamically stable, fluconazole is a drug of choice. For unstable patient or septic shock patient, your kind of candidates like Candida fungus and these medications is a first time therapy. Now, regarding the duration of therapy for catheter-related infection, so minimum 2 weeks antibiotics should be given for the uncomplicated, and 4 to 6 week antibiotic course should be given for the infective endocarditis. For gram-negative infection, duration is up to 7 to 10 days, and for the cons, so 5 to 7 days therapy is enough. Now, next common infection is your urinary tract infection. Incidence of urinary tract infection is up to 30%, so for all admissions. And whenever there is a catheter, that rate is increased. So most common organism is your gram-negative infection like your E. coli and Klebsiella. Fungal infection is very rare, but unstable patient, immunocompromised patient, we can get the candidemia. So risk factor for urinary tract infections are duration. So most important is your duration. So whenever any patient is having catheter, so as soon as your indication is over, we can remove the catheter or change the catheter. Second, length of ICU stay, prior antibiotic use, and higher disease severity. So these are the risk factors for urinary tract infection. Now, there is an increased trend towards the increase the use of your beta-lactam inhibitor or extended spectrum beta gram-negative infection. So for that, piperacillin, tazobactam or carbapenem is very good choice. Aminoglycoside is very good antibiotics for your urinary tract infection, but problem with the aminoglycoside is that it can cause the acute kidney injury or increase in the creatinine, so dose adjustment is required. Now, susceptibility with the fluoroquinolones like your ciprofloxacin, levofloxacin is decreased nowadays. Most important thing is the candida never cause single UTI or only urinary tract infection. So if there is a candidemia or bloodstream infection with the fungal candida or multiple site infection with the candida, so in that case we can start the antifungal therapy. And good drug is your fluconazole, which can cover the urinary tract also. So for the urinary tract, we can start the antibiotic which is having good penetration in your kidney or good penetration in your urinary tract. So your beta-lactam is inhibitor like piperacillin, tazobactam, carbapenem, and fosfomycin. So for uncomplicated urinary tract infection, so sachets of fosfomycin, that is a 3 gram alternate day, is very good antibiotics for gynecological use also and for the urinary tract infection also. And this is also cost effective. So you can use the 2 sachets, 3 gram with a glass of water, and you can cover the urinary tract infections. Now regarding the infective diarrhea, so incidence of diarrhea is almost 30% to 38%. So majority of the diarrhea in ICU are non-infectious, maybe because of poor nutritional practice, maybe because of the antibiotic use. So most of the diarrheas are non-infectious, and infectious diarrheas are because of clostridial difficult infection. So whenever you use higher antibiotics, increase duration, high dose, so there is a high chance that that patient can develop the clostridial difficult diarrhea. And the antibiotic of choice in this case is vancomycin and metronidazole. So oral vancomycin is also good drug for your clostridial difficult infection. So that dose is your 50 milligram 8 hourly, or we can start the tablet metronidazole also 400 milligram 8 hourly, and duration is almost 10 to 14 days. Now abdominal infection. So incidence of pancreatic infection is almost 12 to 37%. So most common infection we get with the gram-negative bacteria. Okay. So these are your Klebsiella, Pseudomonas, and Acinetobacter. Now, if patient is having acute pancreatitis, there is no role of antibiotics. So there is no role of prophylactic antibiotics in the pancreatitis. So whenever we get any infection with the pancreatic necrosis, so in that case we can start the antibiotic which is having good penetration in the pancreas. That is your piperacillin, tazobactam, carbapenem, and your 4th generation cephalosporin. These are the antibiotic which is having good penetration in the pancreas. So if there is infective necrosis, then we can start these antibiotics. Otherwise, prophylactic antibiotic doesn't have any role in the abdominal infection, that is your pancreatitis. Now biliary sepsis, the most common organism is your same, your E. coli, Klebsiella. So empirical antibiotics should be guided by regarding the severity of the disease or cholangitis, microbiological susceptible data, biliary penetration of that antibiotic. So your ciprofloxacin, sulbactam, piperacillin, tazobactam, and carbapenem. That is your imipenem and meropenem. So imipenem is mostly studied drug for the abdomen. So we can start imipenem ciliacid for abdominal infection. And they recommend the monotherapy, that is single antibiotics, and duration is 4 to 7 days. Now regarding the liver abscess, so metronidazole is recommended as the initial antibiotic of choice those who are having the amoebic liver abscess. Second infection is your gram-negative bacterial infection, so we can start your 4th generation cephalosporin, piperacillin, tazobactam, and carbapenem for that. Duration of therapy is 10 to 15 days. Now next infection is your peritonitis. So there are primary or secondary peritonitis. Those patients who are having decompensated liver disease, nephrotic syndrome, or peritoneal dialysis. So in that case, we get a high chance that the patient develop the primary peritonitis. Now, if patient is having any abdominal surgery, immunocompromised case, abdominal trauma, long stay in the ICU, urogenital infection, total parental nutrition, so we get a secondary peritonitis, and stomach and duodenum is the most common site, and we get a most commonly gram-negative infection in the abdomen. So for that, 3rd generation cephalosporin, cefotaxime, and ceftriaxone is a very good antibiotic for the primary peritonitis. So duration of antibiotic we can restrict to the 7 to 10 days. For the secondary peritonitis, so we get a mainly multi-drug resistance infection, so that is the secondary infection. So for that we can start the piperacillin, tazobactam, or carbapenem. Gram-positive infection are very less, but if you are getting the gram-positive infection in the abdomen, so we can start the vancomycin or linezolid for this patient. Now, regarding the CNS infection, so most common CNS infections are with the gram-positive cocci, that is your Streptococcus pneumoniae, N. meningitis, H. influenza, Listeria, Staphylococcus. And in the secondary CNS infection, that is an operated patient for the brain, maybe trauma patient or any craniotomy patient, we get mainly gram-negative infection with the Acinetobacter, Klebsiella, and Pseudomonas. Now, most commonly recommended antibiotics for brain infections are your 3rd generation cephalosporin, and along with the gram-positive cover, that is vancomycin. So ceftriaxone plus vancomycin is the initial drug of choice for the CNS infection, but we have to increase the dose also because brain penetration we have to take consideration, that is blood-brain barrier. So we can use the double dose, that is the ceftriaxone 2 gram IV PLRV. Now, amoxicillin, ampicillin, or benzylpenicillin should be alternative whenever we get a Listeria infection. So immunosuppression patient, immunocompromised patient, age more than 65, in that case we can add the ampicillin or amoxicillin as an empirical choice. Now, skin and soft tissue infection. So for skin and soft tissue infection, we get a gram-positive organism is the most common organism, and drug of choice is your vancomycin, your ticoplanin, daptomycin, and linezolid. So these are the effective drugs for the skin and soft tissue infection. If we are getting the gram-negative infection, so it is very rare, so we can use carbapenem, maybe meropenem or imipenem, and your piperacillin, tazobactam we can add for this patient. For the necrotizing fasciitis, clindamycin we can add in this therapy. Now regarding the sepsis of unknown origin, so any patient who came with the infection, but we doesn't know the site of infection, we doesn't know the cause for infection. So empirical antibiotics should be used, and that is the 2 antibiotics from the different class. That is a combination of the antibiotics we can use for this patient. Ideally, we can start the antibiotic within first 1 hour from the admission. If possible, we can send the appropriate culture, that is blood culture, sputum, or urinary culture, before starting the antibiotics. So these are the recommendations for the sepsis of unknown origin. So for community acquired sepsis, we can give the ceftriaxone and doxycycline, or macrolide antibiotics can be used for the community acquired sepsis. Now, most important thing for the antibiotics is not to start the antibiotic, it is when to stop the antibiotics. So for that we require the antibiotic stewardship. So coordinated intervention, it is to design to improve the measure of appropriate use of the antibiotic by promoting the selection of appropriate antibiotic, right dose, right time, right duration, and right site. So it is antibiotic stewardship. for the effective antibiotic stewardship program results in the optimal clinical outcome and reduce the adverse event. Because whenever we start any antibiotics, so for the increase the 10 days duration, it can cause 3% increase in the adverse event. This adverse event may be the drug toxicity, secondly increase in the resistance, or secondary infection, that is your clostridial difficult infection or any hospital acquired infection. So to run a good antibiotic stewardship program, we require the multidisciplinary approach. And the core element of this antibiotic stewardship program is your committed leadership, your accountability, your expertise in the drug action, duration, tracking the drug resistance pattern, regular reporting, and educate the clinician about the optimal prescription. So this is all about your antibiotic stewardship. So thank you all for inviting me.
Thank you, sir. Now, our next speaker is Dr. Rajendra Sawan sir, and he is guiding on endovascular neural intervention. Service consultant neurologist at Anushka Yamala Center and Chandler Hospital. Analyst as interventional neuroradiologist at various hospitals in Pune. Sir has done ambulance, PMRD, DMD, radio diagnosis at Fuso Medical College, Sassoon General Hospital, Pune. He has neuroradiology at Bangalore at August 2004. Hosted in interventional neuroradiology at Cambridge Care Hospital. International experiences working as consultant interventional neuroradiologist for stroke interventions, CAPSA. This company invented aspiration devices used presently to treat acute stroke cases. Participated in international stroke trial of this device in Germany and USA. Later on, did animal studies for intracranial liberty coils. These devices are now approved by FDA and currently used in patients. Multiple publications, papers, guest lectures at various conferences, CMEs. Please welcome Dr. Rajendra Sawan sir.
Thank you very much for the introduction. I would like to thank IIM Indapur and OB all leading marketing team. We will be seeing various procedures which are done through vascular endovascular access, and I do only neuro interventions, intracranial as well as spinal interventions. So they can be broadly classified into ischemic stroke and hemorrhagic stroke. Ischemic will try to open the vessel, the stenotic regions or the occluded ICLs or vessels are opened in cases of ischemic stroke. And in cases of hemorrhagic stroke, you try to occlude the pathologies, like you try to file the aneurysm, you try to embolize the heavy malformations and heavy fissulas as well as cavity dormant fissulas. So almost 98% 98% of the cases are done through the femoral arterial axis. Very rarely we can have a direct common carotid axis. Occasionally we can use axillary or subclavian axis for these intervention procedures. Now, most important aspect, almost all neuro interventions are done under general anesthesia. Any intervention which is intracranial or about the clavicular region are done under general anesthesia except carotid stenting, which are done under local anesthesia. And we need a good protracted technique to do all these procedures. We start with ischemic stroke, and the commonest procedure is classification is the carotid stenting or vertebral stenting. These are the basic steps in carotid stenting. The first image shows endocarditis plaque and the carotid IC origin. So the first step is employing the embolic protection device distal to the endocarditis plaque. And over the wire of that filter, we do all those manipulations like pre-dilation with the balloon, stent requirement, and then if required, post-dilation. Otherwise, we take that protection device out. The first case is a typical presentation of ischemic stroke, sudden onset very weakness, tone, diabetic, elderly patient, and MRI shows pancyclic watershed therapy. Watershed therapy means the patient has a hemodynamic stroke and we need to open that artery as early as possible. MRI therapy shows significant stenosis at the left ICL. Physical pre-procedure angiography shows very critical stenosis at the carotid bulb region. This is the optic projection which shows that stenosis where the guide catheter was taken, and then the protection device was required in the distal IC. This is the balloon which was used to dilate the vessel. And this is the picture after define the stent. Post-septic picture. We have a comparison here. Pre-dilation picture, post-septic picture. This is how the stent looks like at the end of the procedure. Take that balloon catheters and embolic protection devices out. Now, all these stents which are used are MRI compatible. So these patients can undergo MRI study immediately after the procedure. Some more examples: significant stenosis at the ICL bulb region, post-stenting, planning. This was the case which we treated as a previous case. So patient presented with stroke in cardiac. The CT angiography showed UC occlusion, and when we did a PSA, that showed critical stenosis at the cardiac bulb region. So we opened this cardiac region, and the flow in the MCA is significantly improved. As I mentioned earlier, most of the procedures are done by femoral axis, but occasionally we can have a occlusion of the thoracic or arterial aorta. We can have a significant tortuosity of the arterial aorta or the proximal vein cases. In those patients, I take direct carotid function. The sheath just put into a right common carotid artery. The aorta, the abdominal aorta was totally occluded in this case of aorta arteritis. Significant stenosis at the IC origin, and if you see carefully, the IC bandages are not seen. The IC is completely occluded, the IC origin has significant stenosis. So abdominal aorta is totally occluded. No option but to take direct right common carotid artery access. Then the procedure is there. Use the protection device, pre-dilation, stent requirement, post-dilation. These are the comparative features. Significant improvement in the blood flow. Similarly, we can have a stenting of intracranial artery. So the left vertebral artery just fired to the left mica region at a significant stenosis. Again, self-explanatory dedicated intracranial stent was used. These are the post-stent pictures. If the patient is not affordable, you can have a balloon mounted stent in such patients. Probably balloon mounted stent like this. Intracranial ICS stenosis, stent applied to post-stent picture. Basic artery, very frequent stenosis, multiple TIAs of the posterior circulation, uncertain plaque, and this is the bone compact bone stain, which is post temperature to show the left MCA, one segment, critical stenosis, post temperature. Common procedure nowadays is to patient with a mechanical thrombectomy. Initially we used just live cut thrombus. Now we have devices to capture the thrombus in the vessel and take the thrombus out. So those procedures are called as mechanical thrombectomy devices. Obviously they have to be done precise accurate for anti-circulation. We have to finish that procedure within 6 to 7 hours. For posterior circulation, the makeup period is almost 24 hours because users are invariably bad in posterior circulation. So the makeup period is so wide in posterior circulation. This patient basically trying to concept weakness of the side CT was absolutely normal. Obviously the CT was normal and every normal is was done, but clinically there was no improvement. Patient was therefore looking for eye operations. This is the common cavity angiography, and only the left VCA branches are seen. Left ICA is completely visible. There is no left internal cavity angiography, no opacification. So complete occlusion right from the origin. So I started aspirating the thrombus ICA in the right catheter. So the right catheter with the grooves to aspirate the thrombus, and the ICA started opening with some bleeding defects within the distal survival and infractary ICS. That thrombus was also aspirated, and then I entered into the middle cerebral artery territory with the microcatheter, deployed microcatheter into distal portion of the MCA, and then used thrombectomy device, 85 used validated device here, and now shows complete reopacification of the ICA as well as MCA. Both territory was not opacified initially. Now it's almost near normal appearance of the left ICA circulation. Another patient, 57-year-old patient, on a train journey from Hyderabad to Mumbai, developed weakness to be brought down at Pune. Did MR angiography and MR showed some acute infarcts. Patient was taken for mechanical thrombectomy. This is the further position of ICA, and whole of the MCA is completely occluded. If you see carefully here, there is a good collateral separation coming from the ACA. The main left MCA drum is still not opacified. Again, when we with the mechanical thrombectomy device, here the thrombus is the MCA. The patient shown in good anti-gate flow. One of the commonest things which we noted, which we know in such patient is the reperfusional injury. Sometimes it can be massive intracranial bleed because of the reperfusional injury. And many times patient require the thrombectomy due to mass effect. These are the initial procedure where I used to inject TPA into the thrombus and the thrombus. Basilar artery thrombus, the distal basal is not opacified, completely occluded, the proximal basal is seen. Post thrombectomy picture, distal basilar, cerebellar, and left PCA are very opacified. This is the thrombus which I will get to the thrombectomy device. From ischemic stroke, we go to hemorrhagic stroke. As I mentioned earlier, we try to occlude the pathology in hemorrhagic stroke. It can be aneurysm, it can be edema or any fistula. These are the typical very aneurysms seen on the circle of the wrist. They rupture, they cause subarachnoid hemorrhage and severe headache while sitting on the life of the patient. And we need to treat these aneurysms as early as possible because very high rate of re-rupture. Almost 60-70% of the patients have a re-rupture of those ruptured aneurysms. The second advantage of treating those aneurysms early is we can have a aggressive management of vasospasm going on after the finding of the aneurysm. This is the basic difference. Surgical clipping, which requires requires craniotomy, and endovascular filing it doesn't require any craniotomy. These are the pipes which are used for aneurysm filing. This is the 3D pipe which is used initially, which forms the basket into the stack of the aneurysm. And once the good basket is formed in the aneurysm, we then use this soft helical pipes to fill that basket. So typical presentation: severe headache, unconscious for some time, simply shown diffuse stage. Case is shown is multicoagulated anterior communicating artery aneurysm, which was then treated with the microcatheter taken into the sac of the aneurysm, and multiple pipes were deployed into the sac. And this is the post-filing section, complete operation of the sac. Sometimes the neck of the aneurysm can be large, and you can have a prolapse of this pipe into the parent artery. And in those cases, we need some support at the neck of the aneurysm. We can have a balloon which is inflated across the neck of the aneurysm, and we can have a stent inflated across the aneurysm. This patient again, young lady, diffuse SAH, severe anterior short, wide neck, right ICA, bifurcation aneurysm. So the balloon was kept across the aneurysm into the MCA, and the second catheter was taken into the sac of the aneurysm. This is the microcatheter which was taken into the sac of the aneurysm. This is the balloon catheter across the neck. So subsequently the pipes were deployed into the sac of the aneurysm with balloon inflation. This is the post picture. Pre-picture, post picture, this is the pipe mass. All these pipes are MRI compatible, so patient can undergo MRI study immediately after the pipe procedure. Very small 1.5 to 2 millimeter decom aneurysm treated with balloon assistance. Single helical coil was used. Complete operation of the sac. As I mentioned, occasionally the neck can be very large, and we need permanent support in the form of the stent, which is deployed across the neck of the aneurysm. So really wide IC aneurysm, wide neck. The catheter is deployed across the neck with the MCA, and when the stent is deployed, not sure, these are the markers of the stent going from here to here. And this is the tunnel which is formed by the stent. These are the stent markers. This is the tunnel formed by the stent, and then the coils were deployed into the sac of the aneurysm. Obviously, if the aneurysm is large, we can have some residual portion at the neck of the aneurysm. So I was involved in this animal study for Liberty State System, which was done in California. Next, emerging pathology can be intravenous malformations or intravenous arterial fissulas, which are abnormal connections between the arterioles and the venules with absent capillary bed in between, and that can rupture and cause either intraparenchymal or subarachnoid inflammation. 55-year-old doctor presented with SAH and intraparenchymal bleeds, severe headache, nervous emphysema. CT showed these findings. CT angiography was done and showed urinary fistula along the transverse and sigmoid sinuses, and then it was getting into the cortical vein. So ideally, the blood should go from cortical vein into the sinuses, but here the fistula was competing with the normal venous rhythm of the brain, and it was influxing into the cortical vein. That was why the cortical vein was ectatic, dilated. It had a aneurysm formation with small aneurysm on the venous side. This is the VSA picture. Posterior arterial auxiliary artery like the PCA was supplying the fistula, and this was the draining vein. The microcatheter was taken as distal as possible. The liquid embolic material was slowly injected under the continuous prolonged guidance. We had a perfect graph of onyx. This is the comparative picture. The whole this portion of the feeders, fistula, and the draining vein is considered of the scalp, as well as cystoid aneurysms. Here we have advantage. We did not use the microcatheter. We can puncture these pathologies directly with the needle. So complex cystoid aneurysm, multiple needles from bilateral PC branches. So I use percutaneous needles to puncture that pathology, and this is the embolic material which was injected directly into the scalp cystoid aneurysm. These are the post-embolic pictures. Corresponding post-embolic pictures in arbitration. Carotid artery fistula, spontaneous hemolysis condition of the one eye. You can have a post-traumatic fistula formation. This is the ECA angiography shows opacity of cavernous sinus. Then getting into the ophthalmic vein. So ideally the ophthalmic vein should vein posteriorly into the cavernous sinus. But here, because of the fistula, the venous drainage is reversed. Very minimal supply coming from the ICA. These are the CT pictures. You can give a picture which shows draining facial vein, angular vein, and the superior ophthalmic vein. So I put same axis from femoral venous axis, vein to the common jugular vein, external jugular vein, facial vein, angular superior ophthalmic vein, and then into the posterior portion of the cavernous sinus. Then I started occluding the cavernous sinus. The whole of the cavernous sinus is occluded twice. This is the pre-embolization picture, post-embolization picture. Complete cure of the carotid artery fistula. This is the next day picture. Significant reduction of hemolysis and dilatation. You can have a pediatric patients, vein of calcium malformation, and if you get this single pole vein of calcium malformation, you take phenomenon coming from the left ACL, occluded with liquid embolic matter. Picture, post picture, complete occlusion. Thank you.
Thank you, sir. Like indapur, we are bringing out this thing on our YouTube channel. So kindly like and subscribe our IMN YouTube channel. मला माहिती आहे तुमची उत्सुकता ताणली जाते आत्ताच्या गुजरात टायटन्स वर्सेस CMI. गुजरात टायटन्सने 233 टार्गेट दिलेला आहे. नंबरच्या 21.2 स्कोर झालेला आहे. नाव कमिंग फॉर नेक्स्ट लेक्चर Now next lecture is GI cancers and immuno speaker is Dr. Gandhi. My colleague is Dr. Kiwataki Medical College. He is ready from Athens. He did his DMD research from Amrita Institute of Medical Sciences, Kochi, Kerala. He did fellowship in GI surgery and GI surgery from prestigious National Institute of Medical Sciences, Hyderabad, in 2012. He has several presentations and 42 publications in several peer-reviewed national and international journals. He is a small consultant, GI and HPV certified diploma. Please welcome Dr. Gandhi, sir. Thank you.
Questions are always asked. Advising and we come do some sketching. So I'm a basically a gastrosurgeon. I deal with benign and malignant diseases of GI tract. I do some complex liver and pancreas surgery. We do some advanced and routine laparoscopic surgery. Slowly moving towards robotics. We have a good transplant program also, and have done a fairly good amount of liver transplants over there. So what has changed over the last decade is we don't talk about evidence. Both of them have discussed about it. What is evidence? Um, from surgical point of view, techniques have, I would say, little improved. Is basically techniques have improved because instruments are better. Uh, we in certain diseases we talk about organ preserving surgery. We don't be radical in certain diseases. We have been little aggressive. Concepts have changed a bit. We have all this in under one rupee rupee. We have a good CT. Why I'm talking about CT scan is because basic need, a basic thing about ultrasound, which is I would say an ultrasound is basically an extended clinical examination. CT is always on the cards for any GI disorders. CT and MRI is always on the cards. So having a good CT and good MRI is equally important for a surgeon or a physician. A PET scan is always required because staging for any malignancy, a PET CT is often necessary because it would upstage the disease in certain number of patients. I have put an MR picture over here. Why I have put an MRI is basically in certain diseases, especially in rectal cancers. We all would see your patients with rectal bleeding. If you make a diagnosis of rectal cancer, please ask an MRI pelvis rather than a CT scan. Simply, basically, because the nodal spread, the extent of disease on MRI is better than CT. Why I am saying MRI? Because in rectal cancer, when you see a disease which is going outside the rectum, or when you see a nodes in the perirectal area, that is in the mesorectum, these patients are treated with first chemotherapy and radiation rather than going for front surgery. So MRI would score over CT in patients with rectal cancer. Endoscopic ultrasound is nothing but an ultrasound which there is a ultrasound machine probe which is at the end of the upper GI endoscope, and it's very useful, especially in staging diseases of the upper GI tract. Why I said about better surgery? Because instrumentation has to be better. Surgeons are, all of them are equally good, but if you have good instrumentation, surgery is going to be better, outcomes are going to be better, and everything is going to go good. So one thing we follow is fast track surgery. It's not about doing surgery fast. Fast track surgery is about it's optimization of the patient. It's simple things, telling the patient about the right things, mentally preparing him, giving good analgesia in post-operative period, emulating them early, and starting orally early. We don't keep patients nail by mouth for 3 to 4 days. Colonic surgeries, rectal surgeries, small bowel surgeries, or to a certain extent upper GI surgeries. The initial decades ago, we used to keep them nail by mouth for 4 to 5 days. We start them next day. And the simple thing of starting them early, you require less IV fluids, the nutrition is better, and they recover very fast. So this is nothing. This is called as fast track surgery, or it's called as early recovery after surgery, ERAS. I don't have to discuss about these benefits of laparoscopic surgery. All you know, cosmetically better, less pain, early recovery, decreased complication, less hospital stay, so less money. So this is there. Simple thing about this is this 3 pictures of our patients who undergo cholecystectomy. So earlier we used to talk about open cholecystectomy. Now we don't talk about open cholecystectomy. Hardly we do an open cholecystectomy nowadays. We are talking about laparoscopy. Nowadays we talk about single incision laparoscopic surgery. Same thing, I would say for all other surgeries. This is a patient who had come with dysphagia and was diagnosed with atherosclerotic cardia, and this patient underwent laparoscopic myotomy, which is nothing but cutting across the muscle fibers in the distal part of the 8 centimeters of the esophagus and 2 centimeters of the upper stomach. Malignancy For the stomach and esophagus, remember one thing, what has changed, I don't think surgery has changed much over the last 1 or 2 decades, but the concept has changed. When we see any patient with CA esophagus or CA stomach, if you see the CT scan and if it is reported that it is going beyond the wall of the stomach or beyond the wall of the esophagus, and if there are nodes which are seen, preferably give chemotherapy first and then operate, rather than operating them upfront. The simple reason behind this is, if you give chemotherapy, 3 cycles of chemotherapy prior to the surgery, the chance of recurrence would be less, and these patients would do better in long term. This is again a patient who underwent a distal radical gastrectomy for CS stomach. This is again a hysterectomy. CA rectum we have already discussed. If there are nodes which are seen around the rectum, this patient should undergo a chemoradiation first for a month's period, wait for around 6 to 8 weeks, and followed by surgery. Sphincter, one thing about this thing is, as this I am talking about the patients with a carcinoma of rectum which is involving lower third of the rectum. Initial thinking was all these patients would undergo an abdominal perineal resection, that is an APR. That means removing the rectum and doing a permanent stoma. Nowadays we don't talk about removing full of the rectum and a permanent stoma. We can go to as far as possible because we have better staplers, we have better gadgets, and do an anastomosis, lower down as far as possible. We can remove the internal sphincter and keep them on external sphincter. Still the tone is good, but they have the normal passive stools put down. Patients with colon cancer, rectal cancers who have liver mets, theoretically it would be a stage 4 disease, but still the battle is not lost. Even if they have a liver mets, you can still go and resect the liver as far as possible. If you have good, functioning liver which is left behind, so theoretically it might sound as a stage 4 disease, but even if the primary is resected, that is either in the colon or rectum, you can attack the liver. In sense, you can resect the liver as far as possible. Nowadays, in sense, last 3 to 4 years, we have been doing routine laparoscopic surgery, especially for rectal cancers, especially for colonic cancers, safely. The outcome is almost equal, or I would say better than open surgery. Same again for a patient who underwent laparoscopic surgery for right colon cancer. Same another patient. This slide shows patients with benign pancreatic lesions. I am not talking about pancreatic adenocarcinoma or pancreatic cancers. I am talking about patients with insulinoma, neuroendocrine tumors, or borderline malignant tumors. These patients can undergo something called as enucleation or something called as a central or partial pancreatic resection safely. Something called as organ preserving surgery. This is again a patient with large melanoma of the liver who underwent enucleation. A patient with colorectal cancer with liver met underwent resection. We are trying to push it in the envelope, basically with the help of intervention intervals. When adequate amount of liver is not left behind, we can do something called as portal vein embolization. Increase the remnant part of the liver which can be kept behind and resect the deceased liver as safely as far as possible. This is what is shown over here. Hydrated cyst liver section, CA gallbladder, radical cholecystectomy. This is very close to my heart. Non-cirrhotic portal hypertension. I am talking about non-cirrhotic, not cirrhotic patients. Non-cirrhotic portal hypertension. Often these patients have recurrent upper GI or lower GI, have large varices, they have big spleen on palpations. If you see that hemoglobin, the HbWC platelet is low, you might feel it is cirrhosis, but it is not a liver cirrhosis. These are often young patients, they bleed massively. If their liver function tests are normal, if they have a HbWC and platelet is low, if they are bleeding recurrent repeatedly and they have big spleen, you can do something called a splenectomy with a splenorenal shunt. That is, remove the spleen, join the splenic vein to the renal vein. That portal hypertension is going to improve, and this patient is going to live a normal life. I am sorry to say this, but often all the patients with obstructive jaundice, I am not talking about with medical jaundice, I am talking about obstructive jaundice, that is malignant jaundice. The treatment is not ERCP and drainage. ERCP and biliary drainage is only required for these indications. If there is cholangitis, that means fever or jaundice. If they are not well, they are sick. If the INR is decreased, if they have renal failure, then only you require ERCP and biliary drainage. Otherwise, these patients, irrespective of bilirubin level, can undergo upfront surgery. So this is a patient with pancreatic cancer who underwent a Whipple's pancreatic ureotomy. That is called for a pancreatic hair cancer. Some different patients. The concept of managing acute pancreatitis has changed. We surgeons often don't come into the picture for at least first 4 weeks. It's often aggressive medical therapy and ICU care. If there are collections around the pancreas, they are often treated with fictal drainage. Surgeons come into the picture only after 4 to 5 weeks. If the collections persist, if there is ongoing sepsis, if there is ongoing organ failure, then we come into the picture for doing a necrosectomy. Again, chronic pancreatitis, where you have a atrophic pancreas and dilated duct and stones. Treatment is not ERCP or putting a stent in the pancreatic duct. Treatment is if there is a pain, persistent pain, recurrent pain, which is affecting the quality of life. Treatment is basically either open or laparoscopic, open the pancreatic duct. You have to pour the pancreatic head, remove the stones, and put the jejunum over there. That is called a phase procedure. I will end it over here. It's a long way to go. We have slowly started doing robotic surgeries. I have done a few over the last 6 to 8 months. That's all this. Thank you so much.
Thank you, sir. Now coming to presentation surgery, lab first, Dr. Arun sir, Dr. Suresh sir. Thank you, sir. Now I request our President, Dr. Chaman sir, to participate Dr. Chaman sir. Thank you, sir. Now may I request Dr. Pandu sir to participate Dr. Subha Chandra sir. Thank you, sir. Now may I request Dr. Sudhir Pandey to say what's called for thanks.
Hello. On behalf of Indapur IMA Association, I thank your work staff and our renowned doctors, Dr. Guruji, Dr. Chavan sir, Dr. Gandhi sir, and Dr. Suresh for their excellent presentations for different topics, robotic surgery, antibiotics, and thank you. And
conference. Please go on. Thank you.
अरे हे अपलोड करायला लागतं, अपलोड नंतर अपलोड रे. थांबा यार, हे मध्येच राहिलं काम करा. या या. फोटो काढतो, रेकॉर्डिंग करतो. अरे ए, सागर इकडे. हा झालं झालं.